continue. We continue with the iliac crest and the pubic crest. And the coastal margin. Here we put. I don't have microphone. Microphone is not working, so please keep quiet. So there is here origin of the rectus abdominis. Please, origin of the rectus abdominis, and it is the third backward from anterior to backward. It is the third CPR. So here is the muscle. Here is rectus abdominis. Two fleshy parts, external oblique. And as I said, this is the ninth. Please, please, just because there is no time here, and I have a lot. It's either you help me or I go. So this is the tip of the ninth coca or costal cartilage, as you said, and the line down, meeting a line from the anterior sphenic spine will meet together. So this will be the fleshy part, and this is fibrous part. The fibrous part or aponeurosis is fixed to the midline at the linea alba, but free inferiorly. Free inferiorly except at the pubic tubercle. It is stretched from the anterior sphenic spine to the pubic tubercle, hanging, sagging in this way to form the inguinal ligament. The inguinal ligament is curling in because at this lateral side, if it is curling in like this, it will carry the origins of internal oblique and transversus abdominis. Internal oblique will occupy 2/3 of the length, followed by transversus 1/2 of the length, and this is important. We'll see why, after why. Then this half is not very curled in. This half is halfway curled. In fact, it is horizontal, making for us the floor of the inguinal canal. If I call it, I will call it now the lacunar ligament, which is part of the inguinal ligament. So the inguinal ligament medially is not curling. It is exactly horizontal. So inguinal ligament curling here, but the curling is not curling here, it is horizontal. What rests on this horizontal part of it is the spermatic cord. In a sense, if my hand is representing here, this is inguinal ligament going all the way to pubic tubercle, and from pubic tubercle going back on pectineal line, this will be the lacunar ligament. If this is the pubic tubercle, this will be the crest. So I have here inguinal ligament, pubic tubercle, pectineal line, and in the angle, the lacunar ligament. The head of the triangular shaped ligament is the pubic tubercle. And from pubic tubercle, this is the crest, and here is symphysis pubis. What rests on the crest in this area is the spermatocord. And after resting on the on the crest, it rests on the lacunar ligament. And from the lacunar ligament, it goes to the abdomen through the deep ring, inguinal ring. Then, if the inguinal ligament is ending at the pubic tubercle here, and this is the symphysis pubis, as I said, the spermatocord rests on the crest. So if it rests on the crest, there is no place for the aponeurosis. The aponeurosis will jump over like this. It will curve up. So this part of the aponeurosis is called the inguinal ligament, and it is curling in. This part is nothing but the superficial inguinal ring, and it is curving up to allow the spermatocord to enter and rest on the crest. Here is the inguinal ligament, here is superficial inguinal ring, which is part of the aponeurosis of the external oblique. Here is internal oblique, and as I said, internal oblique is important, and it is the master muscle. Thank you, don't help me. The master muscle of the abdomen. I am this and this tone because we have a lot. This is the sun, the internal oblique. What I care about is the lowermost fibers of it, which are arching. And when the arch exactly like this, from lateral to medial. Laterally, they are coming from the inguinal ligament, from the lateral two-thirds of it. Inguinal ligament, lateral two-thirds. This is for the internal oblique. And where are they going to arch? They are going to arch on the spermatocord. So they arch from anterior to posterior. So the relation of the arching fibers or the inferior fibers of the internal oblique in relation to the spermatocord, at the time, please don't help me, at the time they are anterior. Then at another time they are posterior. At the third time they are superior, making the roof here of the canal, making the anterior wall of the canal, making the posterior wall of the canal. Very important muscle. It formed for me anterior, posterior, and roof of the canal. It shared in all of this. Similarly will be the transversus abdominis. It will do the same, the arching fibers, but it will not occupy two-thirds, the lateral two-thirds of the cord, of the inguinal ligament. It will occupy only half. Why only half? Because I don't need help again and again. Why half? Because the deep ring is midway, half of the inguinal ligament. So from here they will arch also on the cord. But when they arch on the cord, they are not going to be anterior to the cord. They will miss it. But they will arch above it. They will not miss to be its roof. They will not miss to be the posterior wall of the canal. But they will miss to be the anterior wall. Who is going not to miss the internal oblique, because they are coming from two-thirds of the inguinal ligament. If inguinal ligament is this length of my arm, in the middle there is deep ring and superficial ring. This will be the canal between the deep and the superficial. The internal oblique is arising from 2/3 more further than the half. So the internal oblique will be forming anterior wall, roof, and posterior wall, while the transversus abdominis will miss to be in the anterior wall, but it will not miss to be in the roof and the posterior wall. While the posterior wall is being formed by the two muscles, transversus abdominis and internal oblique, will have something called conjoined tendon. This is just seeing or showing us how the transversus abdominis is arising from the internal aspect of the costal margin, interdigitating with the diaphragm. I think we got this together. 7 equals 9. And I repeat it again very fast. This is the sandwich of skin and superficial and deep fascia. And the sandwich is made actually by meat in the middle, 4 muscles. We started by 7, and as I said, we ended by 9. Because we divided this layer into 2, we got rid of this layer, and we counted like this. PETTIESCS, where P is peritoneum, E is extraperitoneal fat, and T transversalis fascia, transversus abdominis, internal oblique, external oblique, scarpa fascia, where it is membranous and devoid of fat, but really it is, as I discussed with Ahmed, your colleague, I told him simulate this to the bag we take from Danube or wherever, which is not passing, it is a waterproof, blood-proof layer, meaning if I have urine in this area, or if I have blood or any fluid which is extravasated, it will not actually go through and it will accumulate in this area and cause swelling, because it is waterproof. No question. And this area of the fat is going to increase or decrease according to what we eat. Here we are. This is important to notice that I have vessels, veins, and arteries in the second and before the last layers. I have vessels before the last and second layers. These vessels here are for sure superficial, and these are deep. Very, very important. And if I have time, peritoneum, what's E? What's T? Transversalis fascia. What's T? Transversus. What's I? And what's E? So again, the important point here is we have vessels placed in the second layer from outside and the second layer from inside. Fat and fat. This is again Camper's scarpa. Excuse me for this. This should have been here to say skin. Here is the layer which I simulated it to the plastic bag we take from the shops, which is waterproof. And between here and there, between this muscle, we have this area, which is here, which is, as I said, dead space. We have here some fascia, but in fact, we avoided to call them. We avoided to call it any name, although it is there. And this is simulated or similar to the transversalis fascia. And I explained that. If you were not there, sir, I explained it. If you don't understand it, I'm sorry. And this is external oblique. And this is its aponeurosis. If I remove this, I will have this shape, the internal oblique. This is the fleshy part. And this is the anterior lamella of its aponeurosis. If I remove the anterior lamella of the aponeurosis of internal oblique, and I remove also, I will get this, which is the rectus abdominis. So I removed external oblique and its aponeurosis. I removed the anterior lamella of the aponeurosis of internal oblique, and I got this. If I remove internal oblique and I remove the rectus, I will get transversus abdominis. In fact, here we went deeper and we removed. So we removed here, as you can see, we removed this muscle, we removed this muscle. We ended up here with rectus halfway. And this here is representing what we call the posterior rectus sheath. Why is it not going down the posterior rectus sheath here? We'll know after that the posterior rectus sheath that was here, you know there is anterior rectus sheath extending from costal margin down to the pelvis. But when we'll go to the posterior rectus sheath, we'll find that it will stop here and migrate anteriorly to join the anterior rectus sheath. If I say that we have 1.5 layers of fascia to make the anterior rectus sheath, and 1.5 layer, and you know why 1.5? Because 1 for external oblique aponeurosis and half for the lamella or the anterior lamella of the internal oblique anteriorly, and posteriorly 1 for transversus abdominis and half for internal oblique. This is 1.5. This 1.5 will leave posteriorly here to go anteriorly. And when it goes anteriorly, it will join the 1.5 all the way down. This is called arcuate ligament. And this represents the change in the direction where actually I got the 1.5 lamella, the posterior rectus sheath, joining the anterior rectus sheath, and I will go over this again. What we see here is transversalis fascia after transversus abdominis. What we see here is extraperitoneal fat. And running in the extraperitoneal fat, I have vessels. These are the layers from above. There are 9 layers. Sir, I can tell you again the layers, one by one, and you can look at them. Peritoneal. And then the E for pre-peritoneal fat, which is extraperitoneal fat. And in the extraperitoneal fat, I will have vessels. Then I have transversalis fascia, After transversalis fascia, transversus abdominis, number 6. And number 5, internal oblique, external oblique, number 4, scarpa fascia and plantar fascia. Very, very illustrative figure. From umbilicus to costal margin, if I want to look at the rectus sheath, it will be looking like this. This is the 1.5 I spoke about, and the other 1.5. We have a layer, complete layer from external oblique aponeurosis, complete layer from transversus abdominis, posterior. And here half a layer and half a layer, meaning anterior lamella, posterior lamella. So, from umbilicus to costal margin, this is the situation. Up above the costal margin, please, this is the situation. Why? Because the costal margin, if we remember, I said the costal margin, we have internal oblique and we have transversus at the edge. Please, thank you. At the edge and just internally here, I have transversus abdominis competing with the diaphragm. This means if I go above it and to see the components of the rectus sheath, I'm not going to see internal oblique or transversus because they are down. What goes up? Only the external oblique. So this is here external oblique, and this is here the fascia coming from it. We don't care about what's posterior, we care here very much. Below umbilicus, what will happen? Below umbilicus, please, midway between umbilicus and symphysis pubis, what will happen? As I said, this 1.5 will go anteriorly to join the other 1.5. And this will be marked by what we call arcuate ligament or linea semicircularis. This vessel, which is very important, inferior epigastric vessel. Inferior epigastric artery is the key organ, the key element in the inguinal area. We have to remember it very well. This artery is going to run first in the extraperitoneal fat. And then after being in the extraperitoneal fat, here it is, as you see here, please notice this, it's piercing a layer. This layer is nothing but transversalis fascia. After piercing transversalis fascia, it is going to run on the posterior aspect of the rectus abdominis. Here, this is transversalis fascia, which is directly in relation to rectus abdominis. Directly in relation to rectus abdominis. I'm saying this 3 times. It can be a matter of a question in an exam. Why? Because practically speaking, it is very important when you go to surgery. When the question comes, and explore whether you know this is the only structure, the direct structure. We have here peritoneum. This is peritoneum, this is extraperitoneal fat. And this is here transversalis fascia. Transversalis fascia is in direct contact with the posterior of the posterior aspect of rectus abdominis, just after midway between symphysis pubis and umbilicus. So in this area, look, here, we are about midway here. So this is exactly in this area, between this brown and this flesh. So, sorry, I beg your pardon. I'm going to correct myself again. Here, this here, this piece is exactly here. We didn't go yet to pierce here. And here, this point, look at this point, focus, when we pierce this. And after we pierce this, we are here in this area between the red and the brown. I repeat it. Here, I am in the extraperitoneal fat, as we know. And then, after I pierce transversalis, I am here. And after I go up, 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 then I will be here in this area. Because this area is demarcating where the posterior rectus sheath join the anterior rectus sheath. So if I go exactly here all the way, if I stick myself to the posterior aspect of the rectus and I go up, 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 I will come to a point where I will find the posterior rectus sheath existing. And when I go to this area, I will not see any more nicely. If I have a laparoscope, I'm not going to see nicely again the inferior epigastric vessels. Clear enough? This represents the same. Here is this part where we were in the extraperitoneal fat, here where we pierce the transversalis fascia, and we are here between transversalis fascia and what's anterior immediately here is the posterior aspect of rectus sheath, of rectus muscle. And then after we go up, 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 I will come to an area where this is existing, which is the posterior rectus sheath. So below arcuate line, immediately, this is the question. This is the question, meaning it can come in the exam like this. Below arcuate line, immediately, the inferior epigastric vessels are between the posterior aspect of the rectus abdominis and transversalis fascia. Above the arcuate line, they are between the posterior aspect of rectus abdominis and the posterior rectus sheath. This is another concept, very, very important concept. The concept is called neurovascular plane. Neurovascular plane of thoraco-abdominal nerves. Thoraco-abdominal nerves are nothing but ventral primary ramus of the spinal thoracic nerve. Ventral primary ramus of the spinal thoracic nerve. In the neck, we have the ventral primary rami from C4 to C8, from C5 to C8. They were involved in the brachial plexus. In the thorax, from number 2 to number 12, they are not involved in anything. Every primary ramus, every ventral primary ramus will run and not involve itself in any complex plexus. And it will run between internal oblique and the transversus abdominis. What we are seeing here is transversus abdominis. Okay? I said before, internal oblique corresponds to the ribs and what between the ribs, whatever you name it, internal thoracic, external thoracic, innermost thoracic muscle, whatever. So when I see a nerve which is thoraco-abdominal running here like this, yes, it is between thoracic wall at its beginning. This is corresponding to the internal oblique, all of it, this and all the muscles. And this is here the transversus abdominis. Transversus abdominis, subcostal, I don't care. Here is a better, far better diagram. Here is internal oblique and here is transversus abdominis. Here is the neurovascular plane. The nerve runs in this area. And while it is here, mid-axillary, it gives a branch which is called lateral cutaneous. This lateral cutaneous will supply the side of the body, but it continues anteriorly until it goes into the rectus abdominis, where it is going to form anterior cutaneous nerve, but it will supply all of these muscles with motor fibers as well. So it is a mixed nerve for sure, because it is anterior primary ramus. But what's important is the neurovascular plane. And when it comes here, it will face something called rectus sheath. We spoke about it. When it faces the rectus sheath, it will pierce it, either laterally or posteriorly, and it will go here to pierce the lateral, the external point of rectus abdominis. Why did I concentrate on this? Because in incisions, paramedian incisions, I will take this away, this way. In paramedian incisions, I will show it to you in a second. I don't take the muscle this way. If I take the muscle this way to enter in the abdomen, I will injure the neurovascular bundle. Look at this, how the paramedian incision is done. Paramedian incision, if this is midline, paramedian should be here. Look at the incision, how I'm going to represent it. This is the incision, anterior rectus sheath. This is how the incision was done here. Then this is to retract the muscle laterally. If I retract the muscle medially, I will injure the neurovascular bundle. Then I continue with my incision. Opposite to the incision I took at the anterior rectus sheath, I will go to the posterior rectus sheath like this. Then I will close it like this, and this will make a sort of a valve. Before this to retract, I will put sutures, and this how paramedian, and the question will come like this. In paramedian incision, we retract the rectus abdominis laterally or medially? Laterally. Now we understand why. This material is my material. I respect you. I don't go anywhere on the net and oh, poof. No. This is your life and my life. Precious. Don't come here to sabotage me. You know the word sabotage?
Yes.
This is a nerve, which is called ilioinguinal, and the other is iliohypogastric. This is iliohypogastric, and this is ilioinguinal. In short, these two nerves, they are coming from L1. L1 is supplying the arching fibers of both internus and transversus. These arching fibers are very important. In what sense? The arching fibers are passing over the spermatic cord like this. They are coming from anterior to posterior. And when there is coughing, this muscle will contract like that. And when they contract like this, they will press here on the whole canal, shutting it. So they are up, and when they go down and shut the canal, so there will be no hernia. We call this the shutter mechanism. If I have an operation here in this area, say appendectomy, and the nerve was injured, the shutter mechanism can disappear, and I will have a direct hernia. We speak now, anatomy-wise, about another concept. I want you to remember that this nerve, which is ilioinguinal nerve, and this is iliohypogastric, both of them were running first in the neurovascular plane. What's the neurovascular plane? Between which muscle? Between internus and transversus. And when this is special for these nerves, they don't go further close to the rectus abdominis. Early on, they will pierce the internal oblique. And when they pierce internal oblique, it means that they are aiming to also pierce the external oblique and appear on the surface. This one will do this. So does iliohypogastric pierce the rectus sheath? No.
Yeah.
It doesn't pierce the rectus sheath. It pierced early, very early. It was in the neurovascular plane. This is the nerve. You can see this is number 10, and number 10 because it is umbilicus. This is 11. This is 12. Iliohypogastric, ilioinguinal. This is how I can know them and name them one by one. 10, 11, 12, iliohypogastric, ilioinguinal. You can see that they pierced early on. They were here between the internus and the transversus, but they pierced the internus. And then no relation to the rectus sheath whatsoever. This means if they are not going to the rectus sheath, can rectus abdominis be innervated by iliohypogastric or ilioinguinal? No. It can be a question. Rectus abdominis is supplied by ilioinguinal nerve. If you say yes, you don't know the anatomy of this area. At all. At all. And this is the trap. This is the trap in the question. One more nerve that shows a special relation, but not very big, is this nerve called subcostal. Instead of piercing the rectus sheath from the side, it is going anterior to the muscle. Anterior to the muscle. Big deal. I will not ask a stupid question like this. I will ask a question like this. Who cares? It pierced laterally or it came behind the muscle or anterior. It is, yes, 10, 11, 12. It is anterior if compared to this. Who cares? But it's still in the rectus sheath. It is still in the rectus sheath. This nerve, the same. It is not going to be forever in the neurovascular plane. Early on, it will pierce the internal oblique, and after piercing internal oblique, it will run where? Very important. This is ilioinguinal, and if I don't continue it, you should study it. Ilioinguinal will run to exit the abdominal wall through our superficial ring. Meaning that this nerve will run and enter what we call inguinal canal, and after entering the inguinal canal, it will leave through the superficial ring to supply the medial area of skin here and the root of the penis and the upper part of the scrotum. Again, ilioinguinal is lower than iliohypogastric, for sure. Ilioinguinal is not going to leave the anterior abdominal wall or exit it to be subcutaneous, to be a cutaneous nerve through piercing the external oblique. No. It is going into the canal. Which canal? Inguinal canal, and leaving the anterior abdominal wall through the superficial inguinal ring. One more thing about the ilioinguinal nerve, and we'll see it once and again. The ilioinguinal nerve does not enter the canal through the deep ring. The canal is between the deep ring and superficial ring. But we'll notice that the ilioinguinal nerve will enter the canal just not through the deep ring. The deep ring is deeper than this, but it will enter the canal hitchhiking. We'll see how hitchhiking. Don't we know that here, this is the roof? This is forming the roof of the canal, the internal oblique? Yes, it is. If it goes with the fibers of the internal oblique, it will enter the canal without needing to be in the deep ring. What goes through the deep ring and the superficial ring is a nerve called genital branch of genitofemoral. And I will show you this if there is time. Here, another view of the two nerves. Both of them do not enter the rectus sheath. One of them is running in the inguinal canal and leaves the abdominal wall through the superficial inguinal. Here we are. Here is inguinal, ilioinguinal, running with the arching fibers and going into the canal, leaving. Thank you so much. We finish at this.